Electroconvulsive therapy. Is it a safe one? Definitely safe one. Very few contraindications exist for the ECT. It is very useful for the Parkinson's patients with depression because it will also decrease the extrapyramidal symptoms of Parkinson also. Somebody goes into catatonic state with schizophrenia, you can give electroconvulsive therapy. But what are the contraindications of ECT? Favorite question of the examiner. What about D? We will anyway have a debate about your rights and our wrongs in the key at the end, no problem. So recent MI, increased ICD, aneurysms, bleeding disorders, any disruption of the BBB, they all stand as the important contraindications for the ECD is what need to be remembered. There is a major depression in the female, fluoxetine SSRI had been given, in spite of that she is not improving. How do you want to treat? Lithium is proved to be a very effective drug when you add it to the antidepressant therapy as a enhancement of the antidepressant effect. After the stroke, for 2 years people are depressed, doctor, after a cerebrovascular accident. So be very sure while sending a CVA patient home, it is not just writing aspirin sufficient. You need to holistically plan how his hemiplegia is going to receive physiotherapy. If he develops vernix or Broca's aphasia, suppose if you take Broca's aphasia, he will understand everything what you talk. So you must tell the relatives, he doesn't talk does not mean he don't understand what you are talking. So that's the reason, be careful while talking to him. Then he can aspirate food, you need to plan everything. So that's the reason job of a neurologist becomes a holistic care in the stroke patients. 2 years they can suffer from depression. Okay doc, shoot me an answer. Epidemic typhus, louse and flea or flea and louse? Oh, you are all ready with rickettsia, eh? That's good doctor. Louse epidemic, flea endemic. Rickettsia is one deplorable topic. Which organism, which rickettsial disease, everything you must remember. Now, pancreatic cancer, doctor, is one of the internal malignancies which can present with depressive symptoms of unknown origin for a long period of time. Next time you are depressed, check your pancreas. Now, coming to the leprosy, type 1, type 2 reactions. What is the difference, doctor? A sudden increase in the T cell immunity is responsible for type 1. And the type 2 is because of the activation of the TNF alpha and the deposition of the immune complexes into the tissues along with a neutrophilic infiltration, which lead to type 2 reaction, is what I want to underscore to all of you. Which is the first sensation to be lost? How many answered it as pain, light touch, temperature? Is the first sensation to be lost. Then pain will be lost. Finally will be lost, first temperature, then light touch, then pain, ultimately deep pressure. This is the order in which the sensations are lost in the case of the leprosy, is what need to be remembered. Pityriasis rosea, Melissasia furfur, which you have to remember. A single outbreak does not elicit a lifelong immunity. Does it? It is false about does not. That is, it leads to lifelong immunity. Remaining statements are all true. There can be, it is not pityriasis versicolor, right? We are talking about pityriasis rosea, okay. Rosea, Christmas pattern, Herald patch, all these things you remember, right? So, it can increase in fall and spring, and a single outbreak tends to elicit a lifelong immunity. Not Malassezia furfur, it is Versicolor. By mistake I thought it was Versicolor, no, Rosea. Next question is Versicolor. Versicolor is due to Malassezia furfur, and simply giving 3 weeks of ketoconazole will not lead to permanent solution. There will be recurrences which keep happening, which need to be fundamentally treated well. Okay, doc. The next question, the question itself is to be modified. That is, we should include false about it, and then C becomes really false, because males are more affected than females. All the remaining statements are actually true. Alcohol can worsen it. Squamous cell, oh, 1 minute. It is not squamous cell carcinoma, right? C doesn't become answer. Then B becomes the answer, because adenocarcinoma is more common in the squamocolumnar junction, I mean cardioesophageal junction. We should modify the question as false and make the B as the answer, because adenocarcinoma is more common than squamous cell carcinoma in the gastroesophageal junction. Okay, doc. Ureter obstructs with retroperitoneal fibrosis, as all of you know very well. Postoperative CEA, very good sensitivity to predict the possibility of any metastasis to the liver. Definitely can be made out by assessing the carcinoembryonic antigen, is what need to be remembered. Now, 30-year-old bleeding per rectum, colitis is there. What is your diagnosis? Very classical of Crohn's colitis. And you will expect non-caseating granulomas to be seen in the case of the Crohn's colitis in a young individual, typically. And you know, Crohn's, unlike ulcerative, is transmural. Hence it involves mucosa, submucosa, muscularis mucosa, everything. It won't be confined only to the mucosa and submucosa, unlike the ulcerative colitis, is what need to be remembered. 2.8 centimeter epidermoid carcinoma is there in the anus. What is the best thing that you want to do? It is the combined X-ray radiation with synchronous chemotherapy is considered to be the best way by which you can be able to control the disease in the case of the epidermoid cancer of the anus, is what need to be remembered. Out of all forms of hiatus hernia, you are more worried about paraesophageal hernia, because paraesophageal hernia is vulnerable to obstruction, strangulation, necrosis, incarceration. Hence it need to be operated, unlike the other forms. Direct inguinal hernia, when do you call it, doctor? It will be medial to inferior epigastric vessel. Colidocal cyst, it has a very high tendency to undergo a malignant transformation, and the current recommendation is, if you discover it, resect the cyst and do a Roux-en-Y colidocojejunostomy. What is colidocal cyst? Congenital dilatation of the biliary duct leading to cystic formation that has a malignant tendency. So you need to remove it and connect that remaining part of the bile duct with the jejunum. Colidocojejunostomy need to be done. Now coming to the stress ulceration, you find multiple sites ulcerations which are very classical. They tend to be superficial, and multiple sites is the nature of the stress ulceration. Okay, doc, give me one confident answer. Nephrotoxicity, ototoxicity, thrombophlebitis, red man syndrome. I know. Red man syndrome we should remove. If we say red man, you will definitely answer vanco. That's right. Everybody is sabotaging the answer. Vancomycin is the typical one. Now coming to Charcot's triad, classically seen in the case of the cholangitis, What is Dieulafoy's lesion? It is one of the sources of GI bleeding. It is found within 6 centimeters distal to the gastroesophageal junction. It is due to a large submucosal artery that protrudes through a mucosal defect which leads to the development of the bleeding, which is the underlying problem in the case of the Dieulafoy's lesion. There is a 4 centimeter mass at the time of appendicectomy found to be carcinoid. Do you want to do hemicolectomy or not? What is the size criteria? For you to do hemicolectomy is an important question. Whenever the tumor size is larger than 2 centimeters, then write hemicolectomy, it becomes a indication. If you do total pancreatectomy, diabetes is definitely a complication, so also diarrhea, hypocalcemia, hypophosphatemia, iron deficiency, pernicious anemia, because pancreas is important for absorption of a lot of nutrients. Intussusception can be preceded by a gastrointestinal viral illness, which is true. Very surprisingly, if you treat it, both surgical or non-surgical, the recurrences are very low. Is a good thing about intussusception. There is a polypoid lesion in the gallbladder. If you do ultrasound, a lot of people will have it. What do you want to do with it? If it is not causing any clinical symptoms, asymptomatic, nothing need to be done. If it causing symptoms, yes, it need to be basically removed. Pancoast can lead to the development of that apical lung cancer, squamous cell carcinoma, can lead to development of Horner syndrome. In thoracic outlet syndrome, subclavian can be compressed, brachial plexus can be compressed, it can lead to carpal tunnel like symptoms. So if the conservative measures fail, you need to basically do surgical decompression of the brachial plexus becomes the management of choice. Cystadenocarcinoma. Generally people without pancreatitis, it is unlikely to find without history of pancreatitis, cystadenocarcinoma of the pancreas is unlikely as a diagnosis is what need to be remembered. Cushing's disease syndrome. This useless terminology had been long back barred from the endocrinology textbooks, but still it will be there, a part of entrance exam, megalomaniac questions. So Cushing's is Cushing with hypersecretion coming from pituitary. Any other cause of the hypercortisolism leading to Cushing becomes Cushing's syndrome, but both of them finally will cause hirsutism, purple striae, easy fragility of skin, diabetes like manifestations, all features of hypercortisolism.